All right, let's talk about pulse oximetry from an OR staff perspective, because here's the thing. As OR techs and nurses, we do not continuously monitor vital signs. That's anesthesia's job. We're on the other side of the drapes, but it is our job to be the context provider for things like blood loss, checking parts of the patient that can't be accessed from the head, managing warming and cooling devices, and communicating what's happening at the field. There are several things that we can communicate as OR staff that might actually be useful. Let's start with the obvious technical stuff like probe placement and nail polish. You may have to move the probe sideways or get another type of probe altogether. So know where the ear probes are, the backup probes, the sticky probes, the pediatric probes, all different kinds of probes, and where the extra cords are, because sometimes the most annoying thing in the OR is promptly finding the stuff that you need. Other rudimentary knowledge is don't put the BP cuff proximal to the pulse oximeter. You'll get a garbage reading when it inflates. Sometimes in the OR it's unavoidable because we're operating on the contralateral arm. But under normal circumstances, try to avoid that. Cold and vascularly compromised patients. If your patient comes out of pre-op cold or they have a condition like Raynaud, scleroderma, or some other vasoconstrictive pathology, the pulse ox might struggle because of the compromised perfusion. Burn patients, trauma patients, hypovolemic, cardiogenic, and septic shock patients can all affect perfusion to the extremities or give you a false reading. So knowing some history on your patient is really important, but oftentimes it's lost in the pressure to hit productivity metrics. If you work in the OR, you know exactly what I'm talking about. It's very easy as staff to just start feeling like you're a trained animal. You set up the OR, you clean it, you set it up again, wash, rinse, repeat. Productivity often prevails at the expense of critical thought, but for everybody, the surgeon, anesthesia, and staff, anybody can get complacent. Just fairly recently, I saw an anesthesia provider distracted on their phone while the surgeon was dropping bone cement. Speaking of bone cement, polymethyl methacrylate polymerization during total joints, that shit fucks with vital signs. The polymerization releases heat and monomers, and when you pressurize the cement into the bone, it can force fat and air into the venous system, causing an emboli. This can lead to hypotension, hypoxia, and arrhythmias. Hypertensive patients may experience lower oxygen saturation, and pre-existing conditions need careful monitoring during this time. Another thing to look out for in the OR is ICG, or indocyanine green. We use it for perfusion assessment to enhance visualization of surgical anatomy. It's super cool. It's something like straight out of Ghostbusters. Anesthesia gives it through the IV, and sometimes pre-op nurses give it, and I've even given it in pre-op myself. But ICG is a dye that absorbs light at a similar wavelength to the pulse ox, creating temporary interference until the dye clears. So watch for that. And sometimes the Bovie can even create electromagnetic interference that can temporarily disrupt the pulse ox reading. And speaking of things that interfere with the reading, melanin. Like many people pointed out in the comment section of my last video, melanin absorbs light. Studies show that Black patients are 3 times more likely to have occult hypoxemia, where the pulse ox reads normal, but their actual oxygen is dangerously low. This disparity was a huge issue during COVID, and new technology is in development, such as green light pulse oximeters and multi-wavelength sensors, but it's not widely available yet. So if you have a patient with darker skin and you get a borderline reading, intervention is crucial. Numerous people also said, what about CO2 and capnography? Yes, absolutely. I'm just breaking it down as an individual piece from which to build on in further videos. Also, a strategy that I implement, but I'm not always perfect at, is to educate myself at the level above my pay grade. There is a great phenomenal podcast called the Nurse Anesthesia Podcast. 5 stars on Apple Podcasts. So go ahead and check that out. It really exposes you to critical care and anesthesia elements that are not emphasized in our training. All right, I hope this helps. See you in the next video.